Good morning. In this video, we will discuss about disorders of lipoprotein metabolism. It can be either hypolipoproteinemia or hyperlipoproteinemia. Both together, we call it as dyslipidemia, which means there is disturbance in the levels of lipids and lipoproteins. Before going into this, I would like to brief you about fasting lipid profile, which is used for diagnosing this dyslipidemia. In our blood, the major lipids present are cholesterol and triglycerol. In this, as this triglycerol and cholesterol, they are water insoluble, they will always be found within the lipoproteins. The cholesterol, it will be distributed in low density lipoprotein, high density lipoprotein and very low density lipoprotein. All these together, we call it as total cholesterol. The normal serum total cholesterol level, it should be less than 200 milligrams per day. Total cholesterol, it should be less than 100 milligrams per day optimally, or at least it should be less than 130 milligram per deciliter. HDL cholesterol, it should be more than 60 milligrams per deciliter in males and more than 50 milligrams per deciliter in females. VLDL cholesterol, it should be less than 30 milligrams per deciliter. This is the cutoff for defining dyslipidemia. If it crosses this cutoff, then we call it as dyslipidemia. Coming to the triglyceride part, this triglyceride is present in both in chylomicrons and also in VLDL in the blood. Usually our lipid profile is done during fasting conditions. That means usually after 10 to 12 hours of fasting. As the half-life of chylomicrons is very short, by this 10 to 12 hours of fasting, all the chylomicron molecules present in the blood will be completely catabolized, which means in fasting sample, the triglycerides will be present only within the VLDL molecule and its level should be less than 150 milligrams per day. Okay, so these are the various parameters which we measure under fasting lipid profile: total cholesterol, triglycerides, cholesterol present in HDL, LDL and VLDL. Okay, among these 5 parameters, most of the labs, they measure only 3 parameters. One is total cholesterol, cholesterol in HDL and triglycerides. From these 3 values, the other 2 values will be usually calculated. The VLDL and LDL values, most of the time it will be calculated. So how it is calculated means, within the VLDL molecule, within the very low density lipoprotein, triglycerides and cholesterol will always be in the ratio 5:1. Okay, we know that we are measuring the triglyceride level. Okay, so if you know the triglyceride level, you can easily calculate the cholesterol present in VLDL by the formula VLDL equal to triglyceride by 5. So when you divide the serum triglyceride by 5, it will give you the VLDL cholesterol level. Next, once you know the VLDL cholesterol level, you can easily calculate the LDL cholesterol using this formula. When you subtract the total cholesterol HDL and VLDL from total cholesterol, you will easily get LDL cholesterol. So these formula which are used to calculate this LDL and VLDL values is called as Fried-Walsh formula. Okay, but this Fried-Walsh formula we cannot apply every time. We can apply it only when the triglyceride levels are less than 400 milligram per deciliter. Suppose if it is more than that, you have to go for direct LDL estimation, and from after finding the LDL, you can calculate the VLDL. Okay, so this is that's it about the fasting lipid profile. So next we will move on to the disorders, actual disorders. First we'll start with hypolipoproteinemia. So there are 3 congenital conditions where the lipoprotein levels in the blood will be very less. They are nothing but A beta lipoproteinemia, hypo-alpha lipoproteinemia, and the third one is Tanger's disease. In A beta lipoproteinemia, the basic biochemical defect is the synthesis of the protein, microsomal triglyceride transfer protein, it will be defective. What is the function of this microsomal triglyceride transfer protein means? It is needed for the synthesis of both chylomicrons and VLDL. Okay, so the lipids will be loaded into the apoproteins and lipoprotein will be synthesized with the help of only this protein. So if this protein is not there, chylomicron production will be affected, VLDL production will be affected. If VLDL is not produced, LDL cannot be formed. So even LDL production will also be affected. Okay, so the blood levels of chylomicrons, VLDL and LDL, everything will be decreased. Okay, so as these chylomicrons are defective, these children who are born with this condition, they will mainly present with fat soluble vitamin deficiencies. We all know that chylomicrons are very much needed for absorbing the dietary fats and fat soluble vitamins. So when chylomicron production is affected in this condition, absorption of fat and fat soluble vitamins will be grossly hampered. So they will present with symptoms of fat soluble vitamin deficiencies. Next, coming to hypo-alpha lipoproteinemia. Alpha lipoprotein is nothing but HDL. Okay, based on their electrophoretic movement, we call the HDL as alpha lipoprotein. So due to some unknown reason, the production of HDL will be decreased in this condition. Okay, so the lipoprotein which will be reduced in the blood in this patient is HDL. Okay, we all know that HDL is a good cholesterol which helps in reverse cholesterol transport. That means it removes the cholesterol from the peripheral tissues and helps in the excretion of the cholesterol. If this HDL is not functioning, what will happen? There will be excess accumulation of cholesterol in the peripheral tissues and it can increase the risk of atherosclerosis. So patients with this condition, they will be more prone for myocardial infarction, stroke, etc. at the very early age itself. Next, coming to the third one, Tanger's disease. Here the defect is ABCA1 protein, ATP binding cassette protein A1. Okay, so what is the function of this protein? Means it helps in the transfer of cholesterol from peripheral tissues into the HDL. Thus, it plays an important role in reverse cholesterol transport or decreasing the cholesterol accumulation in the peripheral tissues. If this protein is defective, cholesterol cannot be removed from the peripheral tissues and formation of HDL will be affected. So in these patients, the blood level of HDL will be very low. Okay, so if HDL is not produced, cholesterol cannot be removed from the body. So these people also, they will present with increased risk of atherosclerosis. Okay, so that's it about the various hypolipoproteinemias. There are three major conditions. One is A beta lipoproteinemia. Okay, so beta lipoprotein means mainly LDL and VLDL. Okay, LDL, VLDL are called as beta lipoproteins. So both of these will be decreased. Okay, microsomal triglyceride transfer protein is defective. This protein is required for both chylomicron and VLDL synthesis. Since this is defective, these levels will decrease in the blood. Okay, in short, almost all the lipoproteins which have ApoB will be found less in the blood. Okay, next coming to hypo-alpha lipoproteinemia. Here HDL production is defective, so they are at the increased risk of atherosclerosis. In Tanger's disease, a protein which is needed for transporter, which is needed for transferring cholesterol from peripheral tissues to HDL molecule will be defected. So HDL production decreases and accumulation of cholesterol in the peripheral tissues increases, leading to atherosclerosis. Okay, so that's it about the various hypolipoproteinemias. Next, we will move on to hyperlipoproteinemia. So this hyperlipoproteinemia can be either due to congenital causes or due to acquired causes. So if it is due to congenital causes, we call it as primary hyperlipoproteinemia. This primary hyperlipoproteinemia can be further classified into 5 types, okay, which is called as Fredrickson's classification of hyperlipoproteinemia. Okay, so type 1, type 2A, 2B, type 3, type 4 and type 5. Totally 6 different types are there. Okay, so about each one of this type, you should know 3 facts. What are the 3 facts means? First thing is, what is the basic biochemical defect? What is the why it is happening? Okay. Second, what type of lipoprotein will be increased? Okay, that is the second thing you should know. Third, what type of lipid, either cholesterol or triglyceride, which will be elevated in this condition. Okay, so these 3 things you should know about or know for each one of this disorder. First, we'll start with type 1 hyperlipoproteinemia. So in this type 1 hyperlipoproteinemia, the basic defect is lipoprotein lipase enzyme or the ApoC2 protein will be defective. We know that both these enzymes, the lipoprotein lipase and ApoC2, they are very much needed for the metabolism of chylomicrons and VLDL. Okay, chylomicrons and VLDL are the triglyceride rich lipoproteins in our body. Okay, so from them the triglycerides can be taken up by the peripheral tissues only with the help of these 2 proteins. So when this is defective, what will happen? Chylomicrons and VLDL cannot be metabolized. Okay, so they will be accumulating. Mainly chylomicrons will be accumulating in this condition. Okay, so chylomicron, if it is accumulating, what a chylomicron is rich in triglycerides. Okay, so triglycerides cannot be taken up by the peripheral tissues, so they will be accumulating in the blood, leading to a condition called as familial hypertriglyceridemia. Okay, so type 1 disorder, they will present with excess triglyceride levels in the blood. Okay, so why there is excess triglyceride level? Because chylomicrons are not metabolized and they are accumulating in the blood. Why chylomicrons are not metabolized? Because of the defect in the lipoprotein lipase enzyme or the ApoC2 protein. Okay, so that's it about type 1 hyperlipoproteinemia. Next, coming to type 2A. Here, the defect is in the LDL receptor protein. So, the peripheral tissues, they will take up the LDL only with the help of this LDL receptors. They will identify the ApoB100, they will bind to it, and they will take the entire molecule into the cell. They will destruct it, and they will be taking up the cholesterol present within it. This is how normally LDL will be metabolized or utilized by the peripheral tissues. Now, whenever there is a defect in this LDL receptor, the LDL molecule cannot be taken up by the peripheral tissues. So, they will be accumulating in the blood. So, here in type 2A, it is LDL that will be accumulating in the blood. So, if LDL is accumulating, LDL is rich in cholesterol. So, the major lipid elevated in this condition will be cholesterol. That is why this condition is also called as familial hypercholesterolemia. Type 2A hyperlipoproteinemia is also called as familial hypercholesterolemia. Next, coming to type 2B. Here, due to some reasons, there will be an increased production of ApoB100. Okay, so due to some defect, there is an increased production of ApoB100. So if ApoB100 is produced more, all the lipoproteins which contains ApoB100 will also be produced in excess. Okay, so can you name the two apoproteins? One is VLDL and the other one is LDL. These are the two lipoproteins which contains ApoB100. Okay, so in this case, both of them will be elevated. Okay, so when both of them gets elevated, we know that VLDL is rich in triglycerides, LDL is rich in cholesterol. So both triglycerides and cholesterol will be almost equally elevated in type 2B hyperlipoproteinemia. Next, coming to type 3, here the defect is ApoE. So what is the function of ApoE means? It acts as a ligand for the hepatic uptake of chylomicron remnants and VLDL remnant. That means the ideal, it helps in the catabolism of chylomicron remnants and ideal. So liver, it will identify the chylomicron remnants and VLDL remnants with the help of ApoE only. So it will recognize ApoE, it will bind it and they will take it and they will be catabolizing. That is what normally happens. When ApoE is defective, the catabolism of ideal will be grossly affected. So there will be accumulation of ideal, intermediate density lipoprotein. In addition, even chylomicron remnants will also be accumulating. Okay, so when these accumulates in ideal or intermediate density lipoprotein, what is the content? What is the constituent? Actually, both triglycerides and cholesterol will be in 1:1 ratio with the ideal, which means both triglycerides and cholesterol will be elevated as same as you see in type 2B. Okay, so in type 2B and type 3, both cholesterol as well as triglycerides will be increased in the blood. Coming to type 4, here due to some unknown reasons, the production of VLDL will be increasing. So if VLDL increases, what type of lipid will be accumulating? Okay, so it is triglyceride. VLDL is rich in triglycerides. So here triglycerides will be accumulating. Next, coming to the last type, type 5. So 5, we all know that it is nothing but 1 plus 4 is 5. So here also in type 5, the defects will be combined effect of type 1 and type 4. So what will happen means here LPL or ApoC2 activity will also be defective. Along with that, due to some reasons, there is also increased VLDL production. Okay, so what are the lipoproteins they will be accumulating? So in type 1 chylomicrons, in type 4 VLDL. So in type 5, where the problem defect is both type 1 and type 4, will be here chylomicrons and VLDL both will be accumulating. Okay, so if both accumulates, what will happen? Both cholesterol and triglycerides will be accumulating. Okay, so these are the various types of primary hyperlipoproteinemia. Okay, so type 1, type 2A, 2B, 3, 4 and 5. So regarding each of this thing, what is the biochemical defect, what is the lipoprotein that is increasing, and what is the major lipid that is elevated? These three things you should know. Once you know the biochemical defect, these two things you can easily make out if you know the metabolism properly. Okay, so that's it about primary lipoproteinemia. Next, coming to the secondary hyperlipoproteinemia, there are a very big list. Okay, almost more than 50 to 100 causes are there which can lead to secondary dyslipidemia. But among that, the most common ones are diabetes mellitus, nephrotic syndrome, hypothyroidism, biliary obstruction or obstructive jaundice, pregnancy, alcoholism, and oral contraceptives. These are some of the commonest causes for secondary hyperlipoproteinemia. In all these conditions, by one or other reason, the LDL levels will be accumulating, whereas the HDL levels will be decreasing. Okay, so this increased LDL and decreased HDL, it leads to increased risk of atherosclerosis and myocardial infarction in all these patients. Okay, so that's it about the various disorders related to lipoprotein metabolism. Thank you.